So welcome everybody to our last cerebral blood flow seminar before the summer break. This seminar will be about intracranial pressure related to physiology. So a few rules of engagement before we start the session. So as you may remember, please keep your microphone on mute and video off throughout the session. There will be time for questions at the end of each presentation. Sorry. If you have any question, usually people have used the chat, so you can do so for sure. And the session will be recorded and posted on the CARNET website. And a few words on the CARNET community. So CARNET is a multidisciplinary community of researchers working on various aspects of cerebral blood flow regulation. And if you are interested in participating or contributing to the network, just email your CV to Kaitlin Records. And there is no fee, membership fee at the moment. And maybe one last issue to cover before we start the seminar. Dr. Jürgen Claassen, who is an associate editor at the JCB-FM, will start a series of point-counterpoint discussion with the journal. So if focusing on early career or earlier career stage scientists. So we have a few examples over here. So if you are interested in contributing, just send your proposition to Jürgen at this email address, and you will have access after the seminar to this page when the seminar will be posted on YouTube. So without any further ado, I will let Dr. Rickards start chairing this session.
Thank you so much, Pat. I'm just going to share my screen because I have just a few slides I'd like to present just to kick off here. Okay, so I'm very pleased to present today the seminar series, or chair the seminar focused on the regulation of brain blood flow as it's related to intracranial pressure. We have some excellent speakers today. We have Syed Imaduddin from MIT, who'll be presenting on a model that they've been developing together with his advisor, Thomas Helt, in terms of non-invasive intracranial pressure estimation with some mathematical approaches. And then he'll be, that technique will be then applied to astronauts who have been flying in space. And Dr. Iwasaki from Japan will be presenting the data from that study in his presentation. So there's two featured speakers, Imad, who will be presenting the model, and then Dr. Iwasaki, who will be applying the model to astronauts. We then have two abstract talks from Alex Hansen and Kaitlin Freeberg, where they'll be utilizing different techniques that actually modify intracranial pressure, and they'll examine what impact that has on brain blood flow regulation. So just to start with, I just wanted to give a few introductory statements in terms of intracranial pressure, just to set the scene for the rest of the talks this morning or today, because I know we have guests and presenters from all over the world today. So this is an excellent presentation or series of presentations showing our global reach. So I think everyone's well aware of the key regulatory factors that control cerebral blood flow, including nerve cell activity, perfusion pressure, sympathetic nerve activity, arterial blood gases, including CO2 and O2, and also the role of cardiac output on cerebral blood flow. There is one measure, though, one regulatory mechanism that I think we're all very aware of, being intracranial pressure, but often we kind of ignore this measurement because, number one, it doesn't change too much under normal physiological conditions, and two, it's very, very difficult to measure. But I just wanted to add this to this series of regulatory mechanisms here, because I think it is an important factor that we do overlook, which can be, which could be contributing to the control of brain blood flow and may actually modify the regulation of brain blood flow under various conditions. So just as a schematic here in terms of the role of intracranial pressure on cerebral blood flow. So I think many of you have seen this diagram before from Phil Ainsley and Shek Zheng's paper back from 2010, just showing the various regulatory mechanisms that control cerebral blood flow. And I've highlighted here the ICP on the right-hand side of the screen. And I think we're all very aware that the impact of intracranial pressure is on cerebral perfusion pressure, where cerebral perfusion pressure is if we subtract intracranial pressure from mean arterial pressure, then we can get a measure of cerebral perfusion pressure. And then that cerebral perfusion pressure can be used to calculate cerebral blood flow if we factor in the resistance of the system. And so, as I say, this is a key regulatory mechanism that is sometimes overlooked, but it does change under various clinical and physiological conditions. And the most common one we often think about in terms of the clinical conditions is traumatic brain injury. So if we have swelling of the brain, obviously the brain is enclosed within the skull, which cannot move and adjust for that increase in tissue volume, and so we'll get an increase in intracranial pressure under that condition. Also, a clinical condition of hydrocephalus, where you have increased fluid on the brain. Obviously, that can also increase the intracranial pressure. Justin Lawley presented a number of studies last week focused on the effect of microgravity on on intracranial pressure and cerebral blood flow. And Dr. Iwasaki, again, will be presenting on that today. And also Justin presented last week a lot of data assessing the effect of postural changes on brain blood flow, and particularly on the effect of postural changes on ICP. In the experimental setting, in addition to these postural changes, we also see changes in ICP with lower body negative pressure. And also, as Justin mentioned last week, there are some effects of just simply using a pillow on intracranial pressure. And so these are all factors that we need to consider from an experimental standpoint. And perhaps the role of intracranial pressure on those responses is something we haven't considered enough so far. There's also the effect of venous occlusion cuffs, which I know Alex Hansen will be talking about today in his presentation, and also just the simple effect of breathing. So just inhaling, regular breathing, the normal tidal volumes will actually modify your intracranial pressure on a breath-by-breath basis. And this is something I'll just briefly touch on in a couple of slides here, just to demonstrate this effect that we probably don't think about too much in our day-to-day operations. So normal inspiration decreases both intrathoracic pressure and intracranial pressure. And you can see on the right-hand side of this slide here, I have tracings. This is actually from a peak model. We have tracings of intrathoracic pressure, intracranial pressure, and right atrial pressure. And you can see that upon inspiration, this deflection of these waveforms, so the downward deflection of intrathoracic pressure, intracranial pressure, and right atrial pressure, and then those pressures then increase during expiration. So during inspiration, we get reductions in pressures. During expirations, we get increases in those pressures. And the pressure gradient that is being generated will draw blood from the periphery and back into the heart. So we get increases in the flow through the inferior vena cava. As you can see here, we have pleural pressure. During inspiration, it decreases. During expiration, it increases. And then these increases in flow through the vena cava. So with each inspiration, we get increases in venous return, and that increase in venous return is dependent on the depth of breathing and the decrease in intrathoracic pressure. Now, there is a way to modify these pressure changes also. So again, here in this figure, we can see the intracranial pressure and the endotracheal pressure, which is an index of intrathoracic pressure. Again, we can see these deflections during inspiration and then increases during expiration. We can actually use something called an inspiratory threshold device, which is basically just a technique that is creating resistance to inspiration. So as an individual breathes through, this is just one of the types of clinically available or commercially available valves that you can actually purchase to further decrease intrathoracic pressure during inspiration. So as intrathoracic pressure decreases during inspiration, this valve will only open once you reach a certain threshold to crack the valve open. And so you can see on the right-hand side figure here that if we use a resistance device here with a cracking pressure of 10 millimeters of mercury, you can see that you get greater reductions in intracranial pressure and endotracheal pressure. And then this is magnified further if you have greater resistance to inspiration. So now we're down to 15 millimeters of mercury cracking pressure, and that reduction in intracranial and intrathoracic pressure decreases even further. So in terms of the physiological responses to this reduction in intracranial pressure, you can see here, this is on the left-hand side is a pig again. During spontaneous breathing, we again see those changes in intrathoracic, intracranial, and right atrial pressures. And then we have aortic pressure and cerebral perfusion pressure on the top tracing. So this is without resistance. And then on the right-hand side, you can see that as we apply that inspiratory resistance, you get greater reductions in intrathoracic, intracranial, and right atrial pressures. And you can see now the fluctuations in aortic pressure and cerebral perfusion pressure are increasing, and the amplitude of these waveforms is also increasing. So you can see that there's some benefit to the cardiovascular system by this reduction in intrathoracic pressure and intracranial pressure. So just in the last slide here, I just wanted to introduce the concept of how we measure ICP in humans. And I know that a number of the speakers will be talking more about this in the next few presentations. And so I think the most common method that we see clinically is the use of these invasive intracranial measurement devices. And we have basically bolts that are secured to the skull. And then the pressure sensors are measuring intracranial pressure invasively. And this obviously is a quite challenging technique, and really only used in that clinical setting where measurements of ICP are so important for the monitoring or maintenance of cerebral blood flow. There's also, under certain conditions, that our patients will actually have these Ommaya reservoirs implanted, and I know Justin Lawley presented on this briefly last week, and Alex will be presenting again on this concept. So these Ommaya reservoirs are actually implanted for delivery of cancer therapeutics to the brain, and so it's a very unusual situation that you'd have these implanted, but it can allow for the measurement of intracranial pressure from these Ommaya reservoirs. There's also the use of ultrasound to measure the optic nerve sheath diameter. And you can see that the ultrasound here is placed over the eye, and then you can actually measure optic nerve sheath diameter. So this has been quite a common technique that's being used in the experimental setting for assessment of intracranial pressure non-invasively. And then finally, these tracings are from Shek Zheng and Phil Ainsley's paper back from 2014, not to demonstrate that they measured ICP, but just to show you the blood pressure and cerebral blood velocity tracings, because these can then be used to actually estimate intracranial pressure from a mathematical standpoint. And this paper from Finale was one that did this. And this is actually in collaboration with Imad, who will be presenting today, and Thomas Helt. So just to demonstrate that you can extract information from these waveforms to then estimate intracranial pressure. And similarly, there is some work going on where you can actually use near-infrared spectroscopy to also provide some estimate of intracranial pressure. So just to show that there are some non-invasive approaches that could be used that don't rely upon these invasive measures of ICP. So with that, I'm going to now pass over to Imad to present his work on the Pseudo-Bayesian model-based non-invasive intracranial pressure estimation. So I look forward to your talk, Imad, and I'll pass over to you now.
So thank you for the very nice introduction, Professor Rickards. I had a few slides in the beginning, but I think you've done a much better job at presenting the sort of the introductory material here. So thank you everyone for coming to this seminar series. It's quite an honor to talk to you about some of the work that we've been doing in our group. So I go by Imad. I'm a graduate student in the electrical engineering department at MIT, where I work in the integrative neuromonitoring and critical care informatics group. I'm advised by Professor Thomas Helt, and we work on a range of biomedical signal processing projects, generally geared towards the neurocritical care or emergency care environments. So one of the ideas that we've been working with, or Thomas has been working with for quite some time, is the determination of intracranial pressure non-invasively using a mathematical model of blood flow to the head. And so that's what I'm going to talk about. So Professor Ricard's already introduced this notion of measuring ICP at the bedside in a clinical environment. So generally, as she mentioned, you might be interested in measuring ICP for traumatic brain injury patients where the injury might be moderate to severe in nature. Likewise, there might be cases of stroke or hydrocephalus or other situations where ICP monitoring is mandated. Now, the gold standard that I think we generally think of for ICP measurement is really this ventricular measurement system, where one might insert a catheter inside the ventricles. This catheter is then connected externally to a pressure transducer and also to this external ventricular drainage system that can be used both to sample the CSF or to drain out excess CSF as necessary. And then there are other anatomical locations where one might insert a sensor to measure the pressure. Of these different anatomical locations that I've illustrated over here, most of these has unfortunately been discontinued in practice, but what we do see quite regularly, particularly in traumatic brain injury patients, are these parenchymal sensors, where a pressure probe is really inserted a few centimeters inside the brain parenchyma. Whichever sensing technique you might use, you would end up with a waveform that might look something like this. So it has a bit of pulsatility, and that's usually riding on top of a mean value, which in healthy patients would be around 10 to 15 millimeters of mercury, even smaller than that. Now, in clinical practice, at least the way we see it in the hospitals that we've worked with, the mean intracranial pressure tends to be given more importance than the waveform itself, although I should say that there is a growing body of literature that does increasingly emphasize the importance of studying the whole waveform itself. But for baseline decision making, whether to perform in a surgical procedure to relieve the ICP or not, generally what one might look at is just the mean value for the ICP. And so my presentation really focuses on estimating the mean intracranial pressure in windows of, say, 20 to 30 cardiac cycles. And then that mean intracranial pressure could then be revised after every 20 or 30 cardiac cycles. That's sort of what the presentation is going to be about. Now, Professor Ricard's already mentioned the optic nerve sheath distension that is used as a surrogate for determining raised intracranial pressure. There have been other approaches as well. For example, one technique that is quite interesting applies external pressure on the eyeball in an attempt to balance the pressure in the CSF. And that really gives you a patient-specific measure of the intracranial pressure, in that no training is involved of any kind, no machine learning is involved. But at the same time, you can only do this to get a spot measurement, say every few minutes, or perhaps even in longer duration, shorter durations. What you don't get with this particular technique is a continuous measurement that is updating every 20 or 30 cardiac cycles, or in some other range. And then people have come up with a whole set of learning-based approaches where some kind of a feature is extracted from measured signals. Those measured signals might be acoustic signals as they traverse the skull. So that's this transcranial acoustic signal-based approach. Or they might use cerebral blood flow velocity measurements and blood flow measurements, and they might learn some features that they can then apply, that they can then use to sort of regress the intracranial pressure intracranial pressure. Now, these techniques are quite interesting in that, in principle, they can be performed continuously, since the measurements that they use, whether they're TCD-based flow velocity measurements or acoustic signals, they can be made continuously. But because of this learning that goes into estimating the ICP, these measurements are usually not patient-specific. So ideally, one would want to have both continuous measurements updating every few cardiac cycles that are patient-specific, so that you have a reasonably high degree of confidence in the measurements that you're getting. So the way that our group approached this problem, and this was work done by Faisal Kashif and then later on by Andrea Fanelli, who was a postdoc in our group, was by constructing a model of the cerebral blood flow So even though blood flow to the head is really a complicated system and it's distributed and so on, the way that we might want to think about it is really in this simple diagram over here, where blood enters the arteries. It enters this near rigid compartment given by the skull. And then it perfuses the brain and goes out via the venous structures, but the veins might be collapsed simply because the venous pressure at the downstream end might be smaller than the intracranial pressure. And so we have this flow limitation where the veins are collapsed simply because the intracranial pressure is a lot higher. So we might encode this pictorial representation in an electrical analog. And that might look something like this, where if we sit really on top of a blood vessel, and if we look at the blood flow through that particular blood vessel, so the middle cerebral artery in this particular case, we might come up with a very simple abstraction of what's going on by coming up with this simple circuit model that looks surprisingly like a Windkessel model that some of you might be familiar with. So what we have here is a capacitor that represents the elasticity of the blood vessels and the brain vasculature. This capacitor is exposed on the one end to the arterial pressure in the vessel that we're studying. And on the other end, it's exposed to the cerebrospinal fluid. And therefore, the intracranial pressure is really what impedes the flow through this capacitor. And on the other hand, we have resistance to this flow of blood that might come in from the smaller vessels in the vasculature. And this flow eventually drains into the veins. However, as I just alluded to earlier, we generally think of the veins as being collapsed. And so what really impedes flow through the vasculature is this dependent pressure source, where the pressure is equal to the ICP, assuming that the venous pressure is a lot smaller than the ICP itself. This is a simple abstraction. It's not accurate at all, but it's a gross oversimplification of the real physiology, but I think it helps us in determining the ICP. And the way we would go about it is assuming that the values for the compliance or the capacitance and the flow resistance change a lot more slowly compared to the ICP than for a data window of 20 to 30 or 60 cardiac cycles. One might write out the dynamics of the system with a first order differential equation that I've kind of written over here. And what we see is the blood flow, the difference between the blood pressure and the intracranial pressure. So that's the cerebral perfusion pressure. And we have these resistance and capacitance elements in here. So what we might be interested in is obtaining measurements for the blood flow and the arterial pressure, and then trying to estimate values for the resistor, the capacitor, and the mean intracranial pressure. So what I'll do subsequently is I'll ignore pulsatility in the ICP, thereby reducing the intracranial pressure to simply its mean value. Now, in principle, we don't really have access to cerebral blood flow measurements in units of liters per minute. So what we have instead are usually just cerebral blood flow velocity measurements obtained via transcranial Doppler ultrasound, for example. This could, for example, be in the form of some kind of optical technique, but what we've always used in our approach are these transcranial Doppler-based measurements. And instead of arterial blood pressure in the middle cerebral artery, what we usually have access to in a clinical environment might simply be some kind of peripheral blood pressure measurement, usually at the radial artery measured using a catheter. But it could, for example, also be something like a finger cuff that you might inflate across the finger. Now, generally, once you have access to the radial arterial pressure, you generally have to apply a hydrostatic offset correction to account for the hydrostatic offset between the radial artery measurement site and the level of the head. So that's usually required. However, so if you assume that the blood flow velocity is a reasonable surrogate for cerebral blood flow, then we can still get away with it, and our circuit representation changes to what I've described over here, where instead of the resistance and the capacitance, we are now estimating pseudo resistance and pseudo capacitances. But it turns out that the ICP term remains unchanged. So we can, in principle, use flow velocity and blood pressure to still estimate the ICP. Now, generally, if you think about this approach, we're using continuous measurements of flow velocity and blood pressure, so we can perform these measurements continuously. And at the same time, because we're just estimating all these parameters, resistance, capacitance, and ICP from the data, these measurements in principle are patient-specific, or at least largely patient-specific. So we think that this approach has some benefits that some of the other approaches that I mentioned may not have. So that's the real idea. We have a circuit representation of blood flow through the head, and we want to obtain certain measurements of the blood pressure and blood flow. And then we want to estimate values for the resistance, capacitance, and the intracranial pressure. So over the years, the different members of our group have come up with different approaches. So I've cited 2 papers over here. And then there's one approach that I've been able to come up with in collaboration with Professor Helt. So I'll talk about that in a bit more detail. And so the way that we go about it is the sort of this Bayesian approach, where we have 2 components. So we take the blood pressure and flow velocity measurements, and then we try and estimate these 3 parameters, ICP, R, and C. And the way we do that is for each plausible value for the mean ICP, we try and estimate values for the resistance and the capacitance. That's usually done in some kind of an optimization-based technique. So usually least squared errors is what we use. And using that, we can come up with model fitting errors. So what I'm showing over here is a landscape of how well this first order circuit representation describes the data that we've collected for a range of possible intracranial pressure values. So what we see over here is that we get a better model fit for lower ICP values in this particular case, and a worse model fit for larger ICP values. So if we look at this landscape, we could think about converting it into a probability distribution of what the ICPs might look like. So converting that residual error plot, we might come up with something like this, where we see that we have a better, that the probability of the ICP being somewhere around 9 millimeters of mercury is more than the probability of the ICP being somewhere around 40 or 50 millimeters of mercury. Once we have a probability distribution, we can now compute a range of metrics. That could be the expectation, the maximum likelihood point where the probability is the highest, or any other metric. And that can serve as our ICP estimate. But this really opens up another avenue where if we have some prior information about what the ICP might be, then we can combine this data-derived likelihood distribution with a prior distribution that we have of what the ICPs might look like in a particular environment. So if we have these 2 distributions, we can combine them, and this is where the Bayesian element comes in. So once we have this posterior distribution, which is the combination of both the likelihood and the prior distribution, we have a distribution that is presumably more accurate, or can lead to more accurate estimates of the ICP. And so what I've shown over here is I ended up estimating the maximum likelihood point, which is somewhere over 9 millimeters of mercury. And it turns out that in this particular hand-picked example, the actual ground truth reference was also at the same point. So that's kind of the gist of the estimation approach. Now, you might argue that over time, one might want to wash out the effects of our initial prior distribution. So we can do that. And once we have a baseline estimate of the ICP that we can obtain with this Bayesian approach that I described, we can then throw out the initial prior distribution and instead use a uniform prior belief where we have no a preconceived notion of what the ICP might be. But instead of using this prior distribution, we can apply it to estimate changes of ICP from one window to the next. And we can add these changes into the baseline to yield estimates that are largely, that increasingly become less dependent on what our initial prior belief was. So that's sort of just a way to reduce the dependence over time on our initial prior belief. So that's sort of the estimation approach, and I've tried to keep the mathematics to a minimum, but I encourage you to read the paper or to reach out to me if you have questions about the actual approach. The way we validated this technique really was first in a pediatric cohort. These were data collected from, I think, 2017 to about 2019 or so at the Boston Children's Hospital. So I should stress that collecting these types of data at the bedside tends to be a tricky prospect, since naturally patient care is usually given priority over data collection. But at the end, we ended up collecting data from 13 patients, about 9 males and 4 females. Some of these were incredibly young people, so about 2 years old or 3 years old. And we had some young adults as well in this population. On average, we had about a median age of 11 years for these patients. And what in all of these patients, what we always had was radial arterial blood pressure, middle cerebral artery velocities, either measured bilaterally or usually on one side. And in most of these patients, we either had ventricular catheters inserted for ground truth ICP measurement, or we had intraparenchymal sensors. So that's where the ground truth ICP was recorded. And in all, we had about 6.5 hours of data. Now, these patients had diverse sets of diseases. So some of these were stroke patients, others were hydrocephalus patients. Certainly, there were some traumatic brain injury patients. So what was nice about this particular data set was that we have this diversity in pathologies. So that was nice. The mean intracranial pressures that we ended up measuring in these patients form a distribution like this, where you see very few examples of the intracranial pressure going beyond 20 millimeters of mercury. And usually most of these patients had ICPs in the range of about 10 to 12 millimeters of mercury. So that's really because the hospital staff wanted to maintain their ICP below in normal ranges. Now, in the interest of time, I won't go through the pre-processing that is necessary in order to get an accurate ICP estimate, but it is a vital part of all this estimation, and I would encourage you to read the paper from Dr. Andrea Fanelli, who was a postdoc at that time in our group, and it really explains how important the post-processing or pre-processing can be. So what we do is there's an automated data extraction technique to segment out regions of data where there might be artifacts. So the flow velocity measurement might be incorrect, or there might be motion in the measurements. Once we have those, since these measurements are coming in from different devices, blood pressure measurements come in from the bedside monitors, flow velocity measurements come in from the transcranial Doppler device. These are usually not time synchronized. And so you have to align the two measurements to the nearest beat. And then a very interesting point is that even though both of these devices will claim to be giving you data at 125 hertz or 250 hertz, in general, there are very slight differences in the sampling rates of these two devices. And so over time, what you end up seeing is that these measurements will drift out over time. And so what Andrea found out the hard way is that you have to apply a sampling rate correction in order to make a subsequent measurement. So that's really important. And once you have all of this, you then need to apply a hydrostatic pressure offset correction to the measured blood pressure in order to have pressure measurements at the level of the middle cerebral artery. So that's sort of the pre-processing that goes into these measurements. Once we have these, we can start applying our intracranial measurement approach. In my technique, data windows of 20 beats. So 20 cardiac cycles, we get one ICP measurement, and then we move on to the next measurement. And here are some examples of ICP measurements. So what I'm showing over here are 3 different examples. So the top panels show the measured intracranial pressure waveform in gray, the reference mean ICP value in black, and the estimated non-invasive intracranial pressure values in red. So there are 3 different examples where the ICP levels were different. And at least in these 3 examples, we see that there is a fair degree of agreement between the measurements. And in the bottom panel, what I'm showing are these values for the pseudo-resistance and pseudo-compliance measurements. So I call them pseudo-resistance and compliance because they're not really in the units that we usually would want them to be, simply because we don't have access to volumetric blood flow. But these measurements, you also tend to get these measurements with our technique. And there has been some work in trying to see whether these measurements can be used to assess cerebrovascular autoregulation in some form or the other. So that's sort of an example of what you might get with our estimation method. Overall, in the 6.5 hours of data, if you start looking at our estimation technique, so if I apply a Gaussian mixture prior distribution at the beginning of my recording, I can get an average estimation bias of about 0.5 millimeter of mercury and a resulting root mean squared error of under 4 millimeters of mercury. Likewise, if you have no prior information, so just a uniform prior belief, the root mean squared error is slightly worse, so about 5 millimeters of mercury, but the bias is still about 1 millimeter of mercury, so that's reasonably nice. And what I'm showing over here at the bottom are really Bland-Altman plots, both in terms of the 20-beat estimation windows, and again, where I averaged the ICP measurements across each recording segment. So I think there were about 100 or so recording segments from these patients. So in either case, we see a root mean squared error of about 4 millimeters of mercury and a bias that is below 1 millimeter of mercury. So that's pretty nice. In order to put these numbers in context, I should say that there have been several studies where people compared the so-called gold standard ventricular pressure measurements with the intraparenchymal measurements. So both of these are invasive techniques, but for physiological reasons or perhaps for other unexplained reasons, usually what some people have found out is that these two measurements can also differ by up to 3 millimeters of mercury of root mean squared error. So in that sense, getting a root mean squared error of just about 4 millimeters of mercury or 5 millimeters of mercury is I think quite encouraging. So this was really the first pass where we validated our technique in this pediatric patient cohort. But since then, we've been able to collect data at other clinical centers across Boston. So for example, here I'm showing estimation results obtained from data that were collected at the Boston Medical Center. So here we had 5 patients, 4 males, 1 female. 3 patients suffered from traumatic brain injury, and there were 2 suffering from either hydrocephalus or brain tumors. These were largely adults, so a median age of about 50 years. And again, we had access to radial arterial blood pressure, middle cerebral artery velocity, and the ground truth ICP was measured with ventricular measurements or parenchymal probes as before. So here I'm showing results estimated with the spectral approach. So this is slightly different from the Bayesian method that I presented. This was developed by Rohan J. Shankar, who is a colleague of mine, again, you see that we have root mean squared errors that are approaching 4 to 5 millimeters of mercury. And so this really does not employ the Bayesian aspect. What we would expect is that if the Bayesian approach is implemented, then you might even get lower errors. And then finally, we had access to this very interesting database from Beth Israel Deaconess Medical Center, again at Boston, where we had 16 patients, nearly all of them suffering from subarachnoid hemorrhage. And these, I believe these were largely adult patients. What the clinicians were able to do for us was, okay, so I can get back to the questions in a minute. So what we did was the clinicians were going through the usual rounds, and they were measuring the velocities in different arterial vessels, in different cerebral vessels. And they ended up providing us those velocity recordings with transcranial Doppler. So because these were done as part of standard clinical care, the data length is very short. So even though these data are from 16 patients, the total data that we accumulated was only about 38 minutes long. But what was nice about this particular data set was that in contrast to the other examples, we do have a few patients where the intracranial pressure exceeds 20 millimeters of mercury. So these are cases where we hadn't tested our approach before. And so what we see over here in the Bland-Altman plot that I've shown is that our system does appear to track the increase in the ICP. So these results were again estimated with the Bayesian approach. So we haven't published these results, but that's what we have. Now here, there were a few examples where the ICP estimation bias is a bit higher, leading to a net root mean squared error of about 6 millimeters of mercury. But I think some of these examples simply have to do with the fact that the data quality wasn't as good as what we had before, primarily because these recordings were collected as part of clinical rounds, and not a lot of care perhaps was given to the amount of artifact going into their measurements. But on the whole, it does at least show that our measurements do perform reasonably well across what is a wide range of ICPs that you might encounter in clinical practice. So that's really a short kind of an introduction to what our approach is. To summarize, what we have is a model-based approach for determining mean ICP that, at least in the reasonably modest data sets that we have, it seems to estimate the results fairly well. The model-based nature of this approach makes it both interpretable in that the parameters that we're estimating are always the resistance, the capacitance, and the ICP, which seem to make some physiological sense. And these are largely patient-specific, particularly if you exclude the prior information. But what I would argue is that including that prior information does tend to improve the resulting NICP estimation accuracy. And so if you do have some prior information of what the ICP might be, I think encoding that in the form of a simple probability distribution can go a long way in improving the estimation accuracy. Having said that, as I said, there is a growing body of literature that emphasizes the importance of both looking at the pulsatility in the ICP waveform and also the mean value. So we think that our approach can estimate the ICP pulsatility, but that work is largely in its nascent state. A fundamental issue with the measurements that we have is that because we don't have volumetric blood flow in units of liters per minute, the capacitance and the resistance estimates that we always observe are pseudo estimates. So they're not in absolute units. And so it's difficult to compare them from one patient to the other. So what would be highly interesting would be if we have volumetric blood flow measurements, can we determine these same estimates as before? Having said that, because our data sets are largely constrained to the normal ICP ranges, it's always desirable to measure ICPs that are outside of these normal ranges. And so that's where a lot of work is currently being done or has been done in our group. So Rohan, whose work I mentioned earlier, recently finished his PhD dissertation where he validated this technique in an animal model where he was able to vary the ICP over a wide range. And I think what he shows is that the estimation approach does certainly perform well over the entire range of ICPs that you might have. A fundamental difficulty in all of these measurements is making these transcranial Doppler measurements, especially at the bedside. So what some of our colleagues here at MIT have done is that they've been working on automated transcranial Doppler measurement. And so what they do is they electronically scan an entire cerebral volume to figure out where the MCA might be, and then they lock onto it and get the CBFV, or cerebral blood flow velocity. At the same time, a slight caveat in our approach is that so far, because we've always measured ICPs at the bedside, we've generally had access to invasive radial arterial blood pressure measurements. So some of the work that I'm currently doing has to do with testing this technique with non-invasive blood pressure devices, for example, the Phenopress or any other volume clamping approach. And as I mentioned, what is slightly what is desirable is to have capacitance or compliance and flow resistance estimates that are in absolute units, and that requires volumetric blood flow measurements. And so some of the work that I've done deals with enhancing the resolution of standard ultrasound so that we can measure both the transcranial Doppler velocities, but also the vessel diameter, so we can have volumetric flow measurements. And so hopefully if we have that in place, then we can start to utilize the values for the resistance and the capacitance that we get out of our estimation technique. And so that sort of wraps up where we are. If you have any questions, I'd be happy to take them, but to end, I think I should acknowledge the effort of naturally my PhD advisor, Professor Helt, also Professor George Verghese, who's a senior professor here, and the work of several postdocs and graduate students, including Faisal, Andrea, Rohan, and even Federico. And then all the clinicians that we've had the chance of working with, At Boston Children's, we had Dr. Robert Tasker and Dr. Frederick Vonberg in particular, and then we had other clinicians. The work that I haven't described yet is really that collaboration with Professor Iwasaki, where we were quite honored to apply our technique to space physiology application. And so that's what you'll be hearing up next. But I should acknowledge that Professor Iwasaki has been very helpful, both in terms of getting us access to this interesting application. And finally, I should state that I've received funding over the years from a lot of different sources, and so I acknowledge them, including Boston Children's, Philips, Analog Devices, and MIT initiatives. So that's kind of where I am. So thank you for your time.
Thank you so much, Imad. That was an excellent talk. Certainly gives us some things to think about in terms of the assessment of ICP with these non-invasive approaches. We have a few questions from the audience, so I'll start off with those. So the first question is from Ronnie Panare. Very interesting work. How do your estimates respond to large changes in invasive ICP?
Right. So as I said, so some of the techniques. So most of the data sets that we've had do not have large changes in invasive ICP. But I think this is the only data set where we do have some ICP estimates that are beyond the 15 or 20 millimeter mercury threshold that's usually used at the bedside. So what we do see is that at least in this very limited data set, we do tend to perform well, and that our estimates are able to track the large changes in ICP. But beyond that, I think it's difficult to answer that. Of course, what I would refer you to is this thesis. I don't know if it's been published yet, but here my colleague validated this technique over a very wide range of ICP, where he was able to raise the intracranial pressure to, I don't know, beyond 60 or 70 millimeters of mercury. And he shows that the estimation technique does indeed perform very well. But I don't know if it's been published yet, but it should be out in a few months, I think. So yeah, that's what I can refer you to.
Great. And it looks from those Bland-Altman plots that perhaps at the higher ICPs, the estimations are even better, right? Because the variation's much tighter around that bias line.
I won't say that. I mean, yeah.
Okay.
the data are too limited to say anything for now.
Okay. Next question is from Alexander Razmowski. Interesting work. Congratulations. Did you also measure the arterial partial pressure of CO2 and cardiac output during your studies?
So I don't believe that we might have access to that in the bedside monitors, but I don't think that we've ever employed that in our estimation. Yeah.
Okay. Yeah. Great. The next question is from Yahya Al-Mualim. Thank you very much for the informative talk. Would you please comment on the large variation on the ICP waveform between mean ICP and non-invasive ICP after 8 minutes? In your opinion, does recording time cause this variation?
So is it somewhere over here? Yes, so I think you're referring to this plot over here. Yeah, so I'm not exactly sure what happened over here. We do see some disruption even in the invasively measured intracranial pressure. So I'm not sure if there was actually something going on at the bedside at this point, which resulted in this TCD measurements getting some artifacts. So I'm not sure. But usually this kind of variation generally suggests some kind of artifact in this flow velocity measurements. But yeah, I would have to go back at the data set to look at that again.
And presumably, Imad, the ICP measures that are being made directly are stable during that entire time. Is that right?
So yes. So these usually are, and I think we tend to correlate that corroborate that with the clinical notes. But again, this would have to be checked. So we do see this sudden jump, and I'm not exactly sure why this happens.
Mm-hmm. Okay. Next question is from Emily Dunlap. What do you think of measuring intracranial artery and vertebral artery blood flow with ultrasound to get velocity and diameter measurements instead of just the MCAV assessment?
Yeah, that's a cool question. So that's something that I'm exploring actively right now. Based on my preliminary results, I think it is feasible, but I think I'd have to perform a few more experiments before I can confidently state that. But if we do have access to those particular measurements, then I think what would be very attractive is that we could have both resistance and capacitance estimates in sort of the absolute units that would then allow us to compare these measurements across different patients. Right now, these R and C estimates are really patient specific, so it's difficult to compare them from one patient to the next.
Mm-hmm. Absolutely.
But I think it might be feasible.
Sure thing. So just a couple more questions. So the next one from Sanjay Kash. Thank you for the in-depth study. Could you comment on the dynamic reasons for the multimodality of ICP on slide 14?
Slide 14. Okay, so sorry, could you repeat the question again?
So I think there's the multimodality. So there looks to be the dynamic reasons for the multimodality of ICP. So I guess there's two
peaks in the...
Yeah, I guess so.
I think so. Okay, so I think with subarachnoid hemorrhage patients, you do tend to have high ICPs. Most of these patients, I think, were in a stable condition. Hence, you see this normal kind of ICP range. But at least one or two of these patients had higher ones. And so these were the cases where I think the patients weren't yet in a stable state. Hence, the multimodality, which I think you're referring to.
Okay, great. Ron Shondoff asks, there is at least one experiment of nature that comes to mind where ICP and brain injury are dissociated. Have you thought of studying patients with idiopathic intracranial hypertension before and after treatment?
I don't think that we've ever done that. But so I'm not, yeah, so more, yeah, okay. So I would have to think about the physiological implications, but certainly to answer your question, no, we haven't had access to that data set yet.
Okay, great. And the very last question, Justin Lawley would actually like to ask you a question with his mic on. So Justin, take it away.
Hey, Syed, nice talk. I guess it's more of a bit of a comment than a question, but I just wonder what, of course, you're very limited, I guess, in having all these invasive measurements. One thing I could suggest is that there are several techniques that you can modulate ICP in healthy humans. And while you wouldn't know the absolute ICP, you could reliably, I would think, change it. So for example, if you do a Valsalva maneuver at 5 millimeters mercury pressure, 10 millimeters mercury, 15, 20, you will get a graded increase in ICP. If you do head down tilt, -5, -15, -20, you'll get a graded increase in ICP. And the Valsalva will do it in a heartbeat, in a second. So you could look at these, if your technique is reliable at measuring very small 3-4 millimeter mercury changes in healthy humans, and you could do it in many, many of them. And yeah, okay, you wouldn't get the absolute, but it might be interesting to try. And I think I got muted. Yeah, just try to use these normal techniques to modulate ICP. Could be quite interesting, at least for these rapid changes, like with a Valsalva maneuver, which you can hold. You can hold a Valsalva maneuver for 10, 15, 20 seconds, and then get many, many heartbeats.
No, thank you. So that's a very nice suggestion. It's something that we are doing. So we are doing some tilt table studies. I don't think we're doing Valsalva maneuvers, but we do tilt table studies to modulate the ICP. And I think you'll see some of that in Professor Iwasaki's talk when he starts. So you will, I think, see whether this technique is sensitive to those changes or not. But yeah, thank you.
Great. Thanks for the question, Justin. And thanks so much, Imad. There might be a couple of other questions in the chat if you would like to answer those just while we move on here. But thanks so much for your presentation. I think that's really set the scene for Professor Iwasaki's presentation. So let's move on to that presentation. So Professor Iwasaki is a professor at Nihon University School of Medicine in Japan. And he will be presenting on the effect of long-duration spaceflight on ICP and cerebral blood flow using this technique that Imad has just presented. So Professor Iwasaki.
Thank you very much, Dr. Rickers, for your introduction and giving me this opportunity to be a featured speaker today at this seminar. Excuse me. Good morning, everyone. My name is Ken-ichi Iwasaki from Nihon University School of Medicine. Today, I'm going to talk about the result from a long-duration spaceflight study on intracranial pressure and cerebral blood flow. The main findings were recently published in the Journal of Physiology. Allow me to begin with a science background in space medicine. A previous study by Mad et al. Reported that 5 astronauts presented with optic disc edema and their ocular alterations after long-duration spaceflight aboard the International Space Station, or ISS. 4 of the 5 astronauts received lumbar punctures after the spaceflight, and all of them showed relatively high levels in the cerebral spinal pressure. And during upright motion on the ground, body fluid shifted toward the lower body due to the Earth's gravity. However, astronauts are in space, body fluid shift towards the upper body and head because of microgravity. And this is referred to as a cephalad or headward fluid shift, or translocation of fluids within the body in microgravity. It is traditionally considered that astronauts experience this phenomenon during the initial phase of spaceflight. Interestingly, these facial photographs are from the same astronaut. So, Mad et al. Proposed that elevated intracranial pressure due to cephalad fluid shift during spaceflight might be responsible for the optic disc edema and other ocular alterations. However, I should point out that Mad et al. Conducted only post-flight lumbar punctures in astronauts with optic disc edema. Since no systematic studies have evaluated changes in ICP from pre-flight to post-flight on a spaceflight crew with and without ocular alterations, changes in ICP from pre-flight to post-flight are still unknown. Therefore, this investigation was conducted to estimate ICP before and shortly after spaceflight using the cerebral blood velocity from the middle cerebral artery and the arterial blood pressure from the radial artery. I consider that a non-invasive method would be accepted with ease and comfort by healthy astronauts rather than an invasive method. Well, prior to this study, we hypothesized that ICP increases after long-duration spaceflight. This slide shows the experiment schedule. 11 astronauts who had been scheduled to stay on the International Space Station over several months participated in this study. And data were collected at the NASA Johnson Space Center before spaceflight, 3 to 6 months before launch, shortly after spaceflight, 0 to 3 days after landing, and after recovery, 1 to 6 months after landing. And about 4 months into their stay on the International Space Station, we conducted in-flight medical interviews from the Tsukuba Space Center in Japan with the participants regarding symptoms related to the cephalad fluid shift. Here you can see probe folder publication. At the first visit to the laboratory at the NASA Johnson Space Center prior to launch, an individually customized probe holder for each astronaut was fabricated using an earplug and dental impression material to place the transcranial Doppler probe in the exact same position in both pre- and post-flight experiment and fix it at a constant angle. And the probe holder was customized to fit each crew member's temporal bone structure and ear. This slide shows the data collection at the NASA Johnson Space Center. First, arterial blood pressure sensors and cuffs, the transcranial Doppler probe, ECG electrodes, and the carbon dioxide sensor were attached. Then, arterial blood pressure in the radial artery was obtained by tonometry, non-invasively. And cerebral blood velocity in the MCL was obtained by transcranial Doppler. The data were recorded for 6 minutes in a supine position and for 6 minutes in a sitting position. The arterial blood pressure was calibrated using a sphygmomanometer curve placed over the left brachial artery held at heart level. Also, to calculate the hydrostatic pressure between the heart and the MCA level, the distance between the heart level and the TCV probe was measured. The result of vision test, complete blood count, and height and body weight were provided by NASA through the datashet plan. In addition to those data, we also acquired medication information and exercise logs to confirm that the participant followed the study constraint, such as these. Non-invasive ICP or NICP was computed using a Pseudo-Bayesian estimation approach that incorporated a model-based estimation, which my co-investigator of this study, Imad, presented just before my presentation today. So I will skip the details of this estimation method. And this slide shows the details of 1 female and 10 male astronauts who participated in the study. Reports from NASA optometrist on the result of in-flight and post-flight vision tests indicated that optic disc edema and caudal holes were detected by optical coherence tomography in 2 of the 11 astronauts. And this slide shows the waveform before and after spaceflight side by side from a representative subject. Now you can clearly see typical stable signals without noise and very similar waveforms before and after spaceflight. Okay, in the next few slides, I will be showing you the main results. So let's move on. Here, graphs for NICP in a supine position. And the left graph shows the result for the 9 astronauts who did not have optic disc edema and caudal holes at pre-flight, post-flight, and recovery. And the right graph shows the 2 astronauts who were found to have optic disc edema and caudal hold at pre-flight, post-flight, and recovery. Please look at the left graph first. The NICP decreased significantly after spaceflight by 15% in the 9 astronauts without optic disc edema and returned to pre-flight levels during the recovery period. Only 1 astronaut showed apparent increases in NICP after spaceflight. Thus, contrary to our hypothesis, NICP did not increase after long duration spaceflight in vast majority, more than 19% of astronauts, suggesting that long duration spaceflight does not systematically or consistently elevate post-flight ICP in astronauts. Okay, please look at the right graph again. Two of the 11 astronauts developed optic disc edema and caudal holes. One of these astronauts showed increases in NICP to relatively high levels after spaceflight, whereas the others showed decreases in NICP after spaceflight. These contradictory results would argue against a primary causal relationship between pathologically elevated ICP and spaceflight-associated ocular alterations. However, further studies such as examining in-flight measurement of ICP on the International Space Station are needed to clarify this. And this slide shows the changes in NICP from the supine to the setting portion for the 11 astronauts at pre-flight, post-flight, and recovery. As expected, all 11 astronauts always showed decreases in NICP from the supine to the setting portion. And of course, the group average decreased significantly from the supine to the setting portion. This graph shows the result of mean arterial blood pressure in a supine portion. No significant changes were found. And this graph shows the result of mean cerebral blood velocity in the MCA in a supine portion. And the MCA velocity increased significantly after spaceflight by 15% and returned to pre-flight levels after recovery. Here is the result for hemoglobin concentration. And the recovery result is based on blood sampling at 30 days after landing. Hemoglobin concentration decreased significantly after spaceflight by 9%. It tended to return to pre-flight levels at 30 days after landing. Here is a graph from a previous report by Trudeau et al. The x-axis is days after return to Earth, and the y-axis is changes in hemoglobin concentration. Green bars show the result of long-duration spaceflight. In their report, the decreases in hemoglobin concentration were about 1.3 grams per deciliter at 3 days after long duration spaceflight, and were mostly recovered 1 to 6 months after return to Earth. So our results are consistent with their results. By the way, this phenomenon is commonly referred to as spaceflight anemia, especially apparent after long duration spaceflight. Okay, let's go back to our result. These two graphs show the relationship between hemoglobin concentration and mean blood velocity in the MCA. Please take a look at the left graph for pre and post-flight data. Here, the x-axis is hemoglobin concentration, and the y-axis is mean cerebral blood velocity in the MCA. And 9 of the 11 astronauts, including 2 astronauts with optic disc edema, showed decreases in hemoglobin concentration with increases in mean cerebral blood velocity in the MCA after spaceflight. The graph on the right shows the repeated measures correlation analysis for pre-flight, post-flight, and recovery data. You can see there is a significant negative correlation between these two indices. Yes. And here's a graph from a previous review paper by Holland regarding cerebral blood flow and oxygen delivery during hemodilution. During this hemodilution, it shows a The x-axis is percent delta arterial oxygen content, and this y-axis is percent delta cerebral blood flow, cerebral blood flow. And as you know, a decreases in arterial oxygen content due to reduced hemoglobin concentration should increase cerebral blood flow to maintain the oxygen supply to the brain. Therefore, from the present result, the decreases in hemoglobin concentration may be partly responsible for the increased cerebral blood velocity via mechanisms of cerebral autoregulation that are working against oxygen demand supply imbalance after long duration spaceflight. Perhaps independently of NICP and ocular alterations. But on the other hand, compared to most of the previous studies, our present results show a slightly larger response in cerebral blood velocity in the MCA against decreases in hemoglobin concentration. I mean, 9% decreases versus 15% increases. This could indicate that other mechanisms or factors to increase cerebral blood velocity in the MCA after spaceflight are involved. Of course, this study has several limitations. Let's look at 3 major limitations. First, intracranial pressure was only measured directly. Intracranial pressure was only estimated non-invasively rather than measured directly. Second, measurements were only made before and after spaceflight, but not during spaceflight. Third, I think everybody is familiar with the limitations using TCD in the MCA. And no studies have provided evidence to reject the potential changes in the MCA diameter after spaceflight. Also, the regulation of blood flow in the MCA may differ from other cerebral arteries after spaceflight. So here are a few take-home messages from this study. First, contrary to our hypothesis, NICP did not increase after long-duration spaceflight in the majority of astronauts, and group averaged NICP even decreased significantly in the 9 astronauts without optic disc edema, suggesting that long-duration spaceflight does not systematically or consistently elevate post-flight ICP in astronauts. Second, independently of NICP and ocular alterations, the present result of mean blood velocity in the MCA suggests that long-duration spaceflight may increase cerebral blood flow, possibly due to a reduced hemoglobin concentration, which is commonly referred to as spaceflight anemia. As I conclude my presentation, I would like to thank the astronauts for dedicating their time and effort toward this study. I would also like to thank the support teams and co-investigators for their assistance and cooperation in performing this study. Thank you for your attention. I would be happy to answer any questions you might have.
Thank you so much, Dr. Iwasaki. That was an excellent presentation with some very unique data collected from astronauts pre and post spaceflight. Just as I wait for questions in the chat, I have a couple of questions for you. What are your thoughts about the dynamic changes in ICP as astronauts come back to Earth? Because you don't have any measurements while they're in space. So do you have any thoughts about the timeline of when these changes might occur, if they do occur?
I think the change is very immediate after landing. I mean, not immediate after, immediate after leave the orbit, because during the microgravity, Dr. Sorry, I forgot the name. Rory shows the little bit higher intracranial pressure during the acute parabolic flight, microgravity, compared with the supine. It means, no, sorry. During parabolic flight, a little bit lower ICP compared with supine. So I think if we include that data to our result, maybe our post-flight ICP is a little bit even lower in supine position compared with in microgravity. So that I think that change is very acute during the transition from the microgravity to the Earth gravity. I think.
Yeah, absolutely. I think it'd be great to get some of these estimations in flight to see what's happening in individual astronauts, for sure.
Yeah.
Great. I have a question in the chat from Xiaoyun Lu. Thank you very much for the informative talk. How should we explain the results of decreased ICP, increased cerebral blood velocity, and decreased hemoglobin after long-duration space mission? Is it the lack of gravity that causes the increase in cerebral blood velocity? The radiation in space causes the decrease in hemoglobin? What are your thoughts in terms of the primary cause for that change in cerebral blood velocity?
Yes, I think primary cause is decreased hemoglobin for increases of cerebral blood flow. And I don't think the radiation in space causes the decrease in hemoglobin concentration. Let me show you a related slide. Mechanisms for spaceflight anemia remains elusive and controversial, but the prevailing wisdom is that plasma volume decreases during the early phase of spaceflight in response to increases in central blood volume due to cephalad fluid shift. This results in increases in hemoglobin concentration and increases in hemoglobin concentration. And these increases in the hemoglobin concentration during spaceflight reduce erythropoietin secretion and subsequently suppresses hemopoiesis, erythropoiesis, leading to reduction in red blood cell volume during spaceflight. Then, after spaceflight, the reduction in plasma volume would be restored faster upon return to Earth than the reduction in red blood cell volume. In other words, reduction in red blood cell volume would recover slowly. Spaceflight anemia may become apparent due to these changes. Then these spaceflight anemia make cerebral blood flow increased, I think.
So the viscosity of the blood might be changing because of these changes in hemoglobin and.
Yeah, it also affects the cerebral blood flow. Yeah.
And as you mentioned during your talk, the reduction in oxygen delivery might be facilitating dilation, do you think, of the vasculature to increase flow? Yeah. Okay, great. So I think Binu Thomas just had a question about the mechanisms of spaceflight anemia, which I think you just covered in your response just now. The next question is from Ron Schondorf. Do you think the increased cerebral blood velocity during spaceflight-induced anemia a compensatory for lowered oxygen delivery or a consequence of the rheology as viscosity may be reduced, which I think, again, we kind of address that as well, right?
But I don't think during a space flight, it doesn't happen because still astronaut has reduced plasma volume and reduced red blood cell volume, equally. So in this report, during space flight, first hemoglobin concentration increased after the initial phase of spaceflight. Then, during spaceflight, it tended to return to the normal value. So still, astronauts don't have spaceflight anemia during the spaceflight. After the spaceflight, astronaut has anemia because of after the spaceflight, the plasma volume reduction quickly restored, then got reduced the hemoglobin concentration. Then it affects the cerebral blood flow. So I don't think during the spaceflight, cerebral blood flow, I don't think during spaceflight, cerebral blood flow changed.
Okay, great, thank you. And just one last question from Alexander Roche. Thank you for this great talk. Do you think the reduction in hemoglobin concentration alongside an increase in cerebral blood flow is an indication of vasoconstriction? Is vasoconstriction an autoregulatory reaction due to lack of gravity? Do you know what the dynamic responses are to the vasculature with microgravity? Is there a dilation or a constriction of those vessels?
Sorry, I don't know.
That's okay. No problem. So some things to think about for sure. Okay. So I think that's the final question we have in the chat, Professor Iwasaki. So thank you so much again for your presentation today. And I'll be moving on to the next talk. So thank you.
Thank you.
Okay, so moving on now to our two abstract talks. So the first is from Alexander Hansen, who is a PhD student at the University of Innsbruck in Austria, and he's under the supervision of Dr. Justin Lawley. And Alex will be presenting on a paper that's been recently published, Reducing Intracranial Pressure by Reducing Central Venous Pressure. And this was actually an interesting collaboration. I'm full disclosure here, I'm a co-author on this paper as well. I was collaborating with Dr. Ben Levine and Justin Lawley as they were developing this study. So this will be a great presentation from Alex, I'm sure, on this paper that's been recently published. So Alex.
Yeah, well, thank you very much, Dr. Rickards, for the great introduction, and thank you very much, both Dr. Rickards and Dr. Broussard for the invitation to give this talk. As Dr. Rickards stated, the title is Reducing Intracranial Pressure by Reducing Central Venous Pressure, and this is in relation to spaceflight associated neuroocular syndrome. And I hope I don't repeat too much from what has already been stated from the great introduction from Dr. Rickards. But during spaceflight, a critical risk factor for astronauts is known as spaceflight neuroocular syndrome, or in short, SONS. And SONS involves a hyperoptic shift, as well as various other symptoms that are related to elevated intracranial pressure, such as posterior globe flattening and increased optic nerve sheath diameter, as well as a few others that were previously mentioned earlier. The hypothesis is that due to microgravity resulting in a cephalod fluid shift, you have an increase in intracranial pressure relative to the increase in intraocular pressure, which then results in the posterior globe flattening. So this figure has intracranial pressure on the y-axis, and on Earth, as humans change from the upright to supine position, we see this initial increase in intracranial pressure followed by a gradual reduction and eventual flattening. So to determine if intracranial pressure is actually pathologically high during microgravity, a recent study using humans in the supine position during parabolic flight showed that actually both intracranial pressure and central venous pressure in the supine position during microgravity was relatively lower compared to the supine position on Earth or during 1G. So when we include intracranial pressure during microgravity within this figure, we actually see that it sits between the upright and the supine position. So it's not exactly pathologically higher in microgravity. So what exactly is causing SONS in space? And since humans spend most of their awake hours in the upright position relative to supine, we can get this estimate of a 24-hour mean intracranial pressure on Earth. And when we compare this to a 24-hour intracranial pressure during microgravity, where we don't have any gravitational fluctuations, we actually do see that it is higher compared to Earth. So the question is how can we elicit or create these gravitational fluctuations that we see on Earth in space? And perhaps the answer is through the manipulation of central venous pressure. And with this, we turn to the Davison equation, which states that intracranial pressure is equal to cerebral spinal fluid production times the outward resistance, and which both of these are quite resilient to manipulation or change. However, when we add in sagittal sinus pressure, and we see that through this outward tract in the venous system, perhaps a manipulation in central venous pressure would correspondingly alter sagittal sinus pressure. And this has been shown within animals where an alteration in central venous pressure causes an alteration in sagittal sinus pressure, which then ultimately correspondingly causes an alteration in intracranial pressure. So this brings us back to our initial question, whereas how to elicit these gravitational fluctuations in microgravity. And two possible countermeasures come to mind. And the first one is the use of bilateral thigh cuff compression. And the second is the impedance threshold device, both of which were previously mentioned by Dr. Rickards. With bilateral thigh cuff compression, it sequesters lower extremity fluid. And with the impedance threshold device causes a reduction in intrathoracic pressure, both of which causes a reduction in central venous pressure. And based on the Davison equation, in terms of the manipulation, they should both cause a reduction in intracranial pressure. So the aim of this study was to document the efficacy of inspiratory resistance breathing via the impedance threshold device and lower extremity venous occlusion with bilateral thigh cuff compression on both central venous and intracranial pressure. We hypothesized that both countermeasures would lower central venous and intracranial pressure with the magnitude of reduction being dependent on the reduction in central venous pressure, which is in line with the Davison equation. So this study recruited 4 male participants, all previously instrumented with the Amaya reservoir for chemotherapy treatment. All participants were free of their malignant disease for at least 1 year prior. All of the testing or the investigation took place post 24 hours bed rest with participants in the -6° head down tilt. Bilateral thigh cuff compression was done at 30 millimeters of mercury for 2 minutes, and the impedance threshold device was at -7 centimeters of water for 5 minutes. Intracranial pressure was measured through a catheter in the Amaya reservoir. Central venous pressure was measured with a central catheter, and arterial blood pressure was measured with a phenometer. So first, to look at the results for the thigh cuff, figure A has central venous pressure on the y-axis. Figure B is intracranial pressure on the y-axis. And we can see that the use of the thigh cuffs at 30 millimeters of mercury didn't really cause any alterations in both central venous or intracranial pressure. However, we did notice that in 2 subjects, there was a slight reduction in intracranial pressure. So we thought that if we would further the compression to at least 40 millimeters of mercury within these 2 subjects, we might see some alteration. But in fact, we actually, as we see, the intracranial pressure and central venous pressure really just flattened out and stayed relatively the same. And in 1 subject, we used 50 millimeters of mercury. And as you can see, it really didn't cause an alteration at all. And just to note, the use of thigh cuff is actually a very popular spaceflight countermeasure. To note. To look at the results for the impedance threshold device, here we have the raw data tracing in 1 subject with intracranial pressure on the top and central venous pressure on the bottom. And we can see that during the 5 minutes of breathing on the impedance threshold device, it caused a reduction in both intracranial and central venous pressure compared to baseline. However, as soon as the participants stopped breathing, indicated here, we actually see that both intracranial and central venous pressure returned to relatively baseline values. And if we look at the mean value over the 4 subjects, again, figure A with central venous pressure and figure B with intracranial pressure, we see that this trend was the same in all 4 subjects, where the impedance threshold device caused reduction in central venous pressure and intracranial pressure. And this was compared to not breathing on the device itself. So when we look at the validity of manipulating the Davison equation, here we formulated a linear regression with the 4 subjects using the impedance threshold device with intracranial pressure on the x-axis and central venous pressure on the y-axis. The open squares are breathing on the impedance threshold device, and the closed squares are not breathing on the device. We see that there's very much a strong positive linear relationship between intracranial pressure and central venous pressure, which is, again, quite in line with the Davison equation. So the take-home messages, first one being, these data really show that breathing on the impedance threshold device acutely reduces central venous pressure along with intracranial pressure compared to baseline breathing. However, it has to be noted that when the participants are not breathing on the device, both central venous and intracranial pressure very quickly returns to baseline values. So this manipulation is very dependent on whether or not you are breathing on the device itself. However, the acute thigh cuff, which, as I previously stated, is a very popular spaceflight countermeasure, really had minimal effect on central venous and intracranial pressure. And lastly, we can see that there was a strong positive linear relationship between central venous and intracranial pressure. And again, this was quite in line with the Davison equation. So I'd just like to thank all the collaborators, as well as obviously my supervisor, Professor Justin Lawley, my laboratory team, and obviously all the collaborators who worked on the data collection and the organization of the study and everything like that. Thank you.
Thanks so much, Alex. That was a nice presentation on that study. So thanks so much for that. So I've got one question from Xiaoyun Lu. Is there any difference in ICP measured from the ventricles compared to that measured through lumbar puncture?
I really can't answer this question. Perhaps Dr. Rickards could could perhaps answer this. Yeah, unfortunately, this is not my bread and butter in terms of research. But yeah, unfortunately, I have not really an idea of that.
And I would defer to Dr. Lawley if he's still on the
Yeah.
call. He may know better than I as well. So we'll pass the buck twice there, Alex. So,
Yeah.
I have a couple of questions just while we wait for others to post. Actually, here we go. We've got another question. Sorry, Andrew Robertson. It looked like ITD breathing while lowering mean CVP and ICP increased the pulsatile amplitude of both. Did you look into this? And do you know what effect this might have on cerebral artery inflow pulsatility?
Ooh, yeah. Yeah, again, we didn't really look into this in terms of cerebral blood flow pulsatility. Yeah,
I can help you with that one, Alex, because we've done quite a lot of work. We've done quite a lot of work with resistance breathing, Andrew, and yes, it does increase the pulsatility in terms of the amplitude of the pulsatility of blood flow coming into the brain. So we're actually interested in that in terms of what effect it might have on cerebrovascular function, whether it be positive or negative. So yeah, it's a great observation you've made there, and certainly of interest. So. Okay, and I had a question for you, Alex, in regards to the change in ICP from the supine to head down tilt in these individuals. Did you have any data on that?
No, well, yeah, I actually don't have any data on that. That would be obviously I would defer this to Dr. Lawley on this data, but I would say that using the head down tilt would increase intracranial pressure.
Mm-hmm.
But unfortunately, yeah, like I don't personally have any data on that, but I believe that Justin did present a bit of that data in his talk last week.
Mm-hmm.
I'm not too sure. But yeah, this would be another deferring to Dr. Lawley.
Sure thing.
Yeah.
And I had another question about your thoughts about chronic interventions that might lower ICP in spaceflight. So you mentioned that with the resistance breathing, it's kind of a very acute on and an acute off, so it doesn't have a sustained effect on ICP. Do you have any thoughts in discussions, perhaps with Dr. Lawley, about other interventions that could be effective?
Yeah, for sure. So obviously, yeah, the use of thigh cuffs is we didn't see that it worked. Like obviously it didn't work within our subject cohort, but perhaps the differences could be, it is a very popular spaceflight maneuver, and perhaps the differences could be in the thigh cuffs used, vessel compliance within our subjects, within the subjects in this current study, based on real astronauts who are probably a little bit more fitter, healthier, and also duration could also be the thing. We only used it for 2 minutes, whereas a longer duration could, you could see a little bit more in terms of fluctuations. Obviously, like I said, breathing on the impedance threshold device, it worked acutely, but probably no one would want to breathe on that device for 8 hours a day.
Mm-hmm.
So the use of lower body negative pressure actually does work. And perhaps I do remember Dr. Lawley mentioning that they are developing special pants or kind of leg sleeves
Mm-hmm.
that could help with this. But again, you can't put someone in a box, in an LB&P box for 8 hours a day. So it would just be, trying to more or less manipulate central venous pressure, and perhaps you could do it in swings where over time you just oscillate it, perhaps. Mm-hmm. and that could be another way to do it. And yeah.
Great. think that lots of options, I guess, in terms of exploring these different maneuvers. So thank you, Alex. I think Justin, you have your mic on. Did you want to contribute to the discussion?
Yeah, sorry, I didn't know. I just would answer your questions for you.
Sure.
The upright supine data is in they're the same subject from our parabolic flight study. So I remember, it's a long time, but ICP changed from about 14 millimeters of mercury to about 3 or 5, I guess. I think generally, if I remember, at least the 3 studies off my head, ours, Dr. Peterson's, and the group from Sarah Quavander is present. The change from the upright to the supine is around about 10 or 11 millimeters mercury normally. Mm-hmm. And normally ICP is around 0 or negative, depending whether it's measured intraventricular or tissue pressure. Mm-hmm. That was one you deferred to me, putting me on the spot. And the lumbar one is, yeah, there's some data to suggest there's some differences, but normally I think for the most part, again, Anders Öklund and Jan Malm, they really have a lot of this kind of data from the lumbar measurement. And I think once you account for the hydrostatic gradient, and most of the time they're in the supine position on the lateral side, they're normally quite accurate for CSF pressure for the most part. So of course, I don't know what the difference is with a single lumbar puncture, but they always use a catheter. So therefore they're having long duration continuous recordings, and therefore you much more accurate, I think.
Great.
So they're my 2 cents.
Thank you, Justin. I appreciate you joining in to help with those questions. So great. All right, Alex. Thanks so much for your presentation. I'm going to move on to our final talk for this morning or for today. So the final presentation is from Kaitlin Freeberg. Kaitlin is a PhD student with Dr. Doug Seals from the University of Colorado in Boulder in the US. Her presentation is time-efficient inspiratory muscle strength training improves cerebrovascular function in midlife and older adults with above normal blood pressure. So this is a slightly different approach in terms of the use of resistance breathing to try and improve cerebrovascular function. And it may have some impact on ICP. I know that Kaitlin didn't measure this, but certainly that's something that could be explored. So Kaitlin, I'm going to pass over to you for your presentation.
Great, thank you. Can you see the slides all right?
I sure can, yep.
Perfect. All right, thank you for the introduction and thank you for inviting me to give this presentation. Aging is the primary risk factor for cardiovascular diseases, which are the leading cause of death in the United States as well as other developed and developing countries. In addition to cardiovascular diseases, advancing age is also associated with an increased risk of cerebrovascular diseases, such as stroke, as well as cognitive impairment, Alzheimer's disease, and related dementias. Part of this increased risk may be driven by age-related increases in systolic blood pressure, endothelial dysfunction in the peripheral vasculature, such as the brachial artery, as well as cerebrovascular dysfunction. Healthy lifestyle strategies, such as habitual aerobic exercise, help to lower blood pressure and improve peripheral endothelial function and may promote cerebrovascular health. Current physical activity guidelines suggest that adults perform either 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercise each week. However, less than 40% of midlife and older adults, that is adults 50 years of age and older, actually meet physical activity guidelines due to multiple barriers to adherence. The most commonly reported barrier to adherence is time availability. However, financial costs, lack of access to gym facilities or other safe built environments, transportation issues, and physical limitations are all important barriers to adherence. And strategies that can effectively improve cardiovascular health while overcoming these barriers are needed. High resistance inspiratory muscle strength training, or IMST, is a time-efficient form of physical training that utilizes the diaphragm and the accessory respiratory muscles to repeatedly inhale against a resistance using a portable handheld device. This figure illustrates the inspiratory pressures elicited by different types of respiratory or aerobic exercise training protocols. And as you can see, high resistance inspiratory muscle strength training provides us really unique training stimulus by requiring individuals produce these large inspiratory pressures that are much greater than that of meditative breathing, and even 2 to 3 times greater than that of maximal intensity aerobic exercise. Previous studies have assessed the effects of low resistance IMST, which is typically performed at a resistance at or around 30% of maximal inspiratory pressure. However, these low resistance training protocols are often 30 to 60 minutes long and therefore provide no real time-saving benefits compared to conventional aerobic exercise. On the other hand, a high resistance IMST protocol has been developed whereby individuals perform only 30 inhalations at 75% of maximal inspiratory pressure, requiring only a 5-minute time commitment each day. So the time efficiency, together with the portable nature and the relative affordability of these devices compared to gym memberships or expensive exercise equipment, suggests that high resistance IMST may overcome multiple barriers to adherence. Our laboratory recently completed a pilot study and found that compared to a low resistance sham training group, 6 weeks of high resistance IMST lowered blood pressure in midlife and older adults with above normal blood pressure at baseline. Additionally, we observed that 6 weeks of high resistance IMST improved peripheral endothelial function as measured by brachial artery flow mediated dilation. In light of these promising results for the efficacy of high resistance IMST for lowering blood pressure and improving peripheral endothelial function, we were interested in whether the benefits of this training protocol were also transduced to the cerebrovasculature. So we sought to investigate whether 6 weeks of high resistance IMST could improve measures of cerebrovascular function in an otherwise healthy group of midlife and older adults with above normal blood pressure, a population at increased risk of cerebrovascular dysfunction. Our laboratory's pilot study was a double-blind, randomized, sham-controlled parallel group design, and 36 participants were equally assigned to either high-resistance IMST or low-resistance sham training. High-resistance IMST consisted of 30 breaths per day at 75% of maximal inspiratory pressure, performed 6 days a week for 6 weeks, and sham training was an equivalent protocol with the exception of breaths being performed at 15% of maximal inspiratory pressure. To gain insight into the effects of IMST on cerebrovascular health, middle cerebral artery blood velocity was measured using transcranial Doppler, while participants first breathed room air and then air containing 5% CO2. We then calculated cerebrovascular reactivity as an index of the responsiveness of the cerebrovasculature to the vasoactive CO2 stimulus. Additionally, cerebrovascular conductance index reactivity was calculated to further provide insight into the cerebrovascular responsiveness to CO2 independent of blood pressure. And then pulsatility index was calculated to assess the transmission of pulsatile blood flow into the cerebrovasculature. So this table shows subject characteristics for the subset of participants who performed these cerebrovascular function measurements. Participants were in their early to mid 60s and generally healthy other than having baseline blood pressure classified in the stage 1 hypertension range. High resistance IMST induced similar blood pressure reductions in this subset of subjects compared to the overall cohort. And importantly, none of the other subject characteristics changed over the course of the intervention, suggesting that improvements seen with high resistance IMST were not due to changes in these other important cardiovascular disease risk factors. So this graph illustrates cerebrovascular reactivity measured before and after sham training as depicted with the black to gray bars, and before and after high resistance IMST depicted with the black to gold bars. Our preliminary results showed that cerebrovascular reactivity was increased after 6 weeks of high resistance IMST, but not sham training. And this increase was also evident for cerebrovascular conductance index reactivity, suggesting that improvements in cerebrovascular CO2 reactivity were likely independent of any changes in blood pressure induced by that hypercapnic challenge. We also assessed whether relations existed between the cardiovascular and the cerebrovascular improvements invoked by the intervention. And we observed that increases in cerebrovascular conductance reactivity were not related to reductions seen in systolic blood pressure. However, increases in cerebrovascular conductance reactivity were related to increases in peripheral endothelial function improvements. However, pulsatility index did not change after 6 weeks of high resistance IMST or low resistance sham training, as you can see here in the table, with pulsatility index during normocapnia in that first row and during hypercapnia in that second row. To summarize, 6 weeks of high resistance IMST increased cerebrovascular reactivity, an index of cerebrovascular health, and this improvement remained when accounting for potential changes in blood pressure. And additionally, this may be related to improvements in peripheral artery endothelial function seen with the intervention. However, there was no effect of high resistance IMST over the course of these 6 weeks on pulsatility index. So together, these preliminary results suggest that high resistance IMST is a promising time-efficient intervention for improving select measures of cerebrovascular function in midlife and older adults with initial above normal blood pressure, a population at increased risk of developing both cardiovascular and cerebrovascular diseases. With that, thank you for your attention, and thank you to my mentor, Dr. Seals, Dr. Craig Head, and the entire Integrative Physiology of Aging laboratory, as well as our collaborators and funding sources. I'm happy to take questions.
Thank you so much, Kaitlin. That was an excellent presentation on a really novel intervention that can, it looks as though it can improve both peripheral vascular function and perhaps cerebrovascular function as well. So just while we wait for questions to come in the chat, I do have a couple for you. So you mentioned that there was an association between the improvement in CO2 reactivity and the assessment of peripheral vascular function. Do you have any thoughts about how or whether it might be improving cerebrovascular function with the same kind of mechanisms?
Yeah, so when we looked at peripheral endothelial function, we also used an ex vivo approach using human umbilical vein endothelial cells. We exposed them to serum from subjects before and after the intervention and saw that that serum improved nitric oxide bioavailability and reduced oxidative stress. And so it's possible that these same mechanisms may be involved in the improvements seen in cerebrovascular function as well. Yeah,
I mean, that'd be really intriguing to kind of explore that even further.
Definitely.
With some approaches, I know Ryan Hoyland and Phil Ainsley have developed a CO2 reactivity test that may address the endothelial function question with the very acute CO2 stimulus rather than the prolonged stimulus that you used. So there's plenty of room for further exploration, I think. So excellent. And seeing as we're talking a lot about ICP today, do you have any thoughts about what type of changes in ICP you're inducing with your inspiratory muscle strength training device? In a kind of related question, do you know how much intrathoracic pressure is decreasing upon each breath?
Yeah, so definitely, like you said, we don't have the data for intracranial pressure, but these inspiratory breaths against resistance are definitely causing these large reductions in intrathoracic pressure. The pressure threshold device that we're using, individuals are having to breathe against around 80 centimeters of water. And so definitely much larger intrathoracic pressures than the literature's previously assessed. And so it's really interesting to think that intracranial pressure may also be decreasing during these acute bouts of IMST and potentially improving cerebral blood flow in that way.
Absolutely. I can imagine that the shear stress within the cerebrovascular may be increasing because if you may have those concomitant reductions in ICP, increasing flow on a breath-by-breath basis. So again, some interesting areas for exploration. So
definitely.
Great. I have a question from AJ Rosenberg in the chat. Great talk. Did you compare the relationship between brachial pulse pressure with cerebrovascular reactivity conductance index?
So no, that's a good idea. I did not look at pulse pressure and the relation between pulse pressure and CVR. So that would be definitely something to see.
Mm-hmm.
That would.
Yeah, I guess the pulsatility of blood flow may be changing as well with this approach. So
right.
Yeah, absolutely. And I have just one more question for you. In terms of the application of this approach is potentially in older individuals who are hypertensive, and that was your target group in this study. Are there any contraindications that you would advise for this cohort of individuals?
Yeah, so we also assessed safety and tolerability in this pilot study as well, and found that it was highly tolerable. And the main kind of contraindications that we saw were some mild lightheadedness from subjects and some neck muscle soreness. Both of these were reported kind of towards the beginning of the study when individuals were kind of getting used to the intervention and did not cause any of the subjects to drop out of the study. So I think in general, it was a highly tolerable intervention and yeah.
Great. So you're getting, I guess, respiratory muscle strength plus neck muscle strength, perhaps,
right,
as well,
right.
which are the contributing musculature to respiration. So
yes,
excellent. Well, that's great, Kaitlin. Just one more question. Andrew snuck in here. Andrew Robertson, great talk. Did you have to increase the device resistance over the training period as the inspiratory muscles adapted?
Yes, definitely. So we started with training at 55% of the individual's maximal inspiratory pressure, and then increased it the next week to 65%, and then increased it to 75% for the remainder of the intervention. And each week after that, we also assessed their maximal inspiratory pressure and changed the device's absolute resistance in order to keep them training at 75% of maximal inspiratory pressure.
Excellent. That's great. Well, thanks so much, Kaitlin. I really appreciate your contribution to today's session. And that wraps up today. So I'd like to thank all of our speakers for their great presentations today. I think providing some unique insights into the role of intracranial pressure on cerebral blood flow regulation. And that actually wraps up our seminar series for this semester. So I'd like to thank everybody on behalf of Patrice and myself, thank everybody for their participation in this seminar series, really over this last year. And please stay tuned for the next installment of seminars coming up in the fall for those of us here in the Northern Hemisphere. And we'll be posting the information about that shortly. So thanks everyone, and have a great rest of your day.
Thank you. Bye-bye.